During this COVID-19 pandemic, the priority is to keep healthcare workers safe. COVID-19 patients can have a fast respiratory deterioration and need urgent support. Intubation is a high-risk aerosolizing procedure where the virus can transmit to the people in close proximity. An early and planned intubation that can reduce the risk of transmission is recommended if possible. You are about to watch a simulated urgent intubation of a suspected COVID-19 infected patient, where enhanced airborne precautions were followed to enhance safety. A protected intubation generally includes the following steps. Number 1, identification that a patient is deteriorating and that protected intubation is required. Number 2, assembling the team. Number 3, having a team pre-brief. Number 4, donning of personal protective equipment. Number 5, intubation. Number 6, doffing of personal protective equipment. Number 7, the debrief with the team.
Hi John, my name is Kevin. I'll be your nurse today. I'm just going to do some vital signs.
This patient is a 67-year-old man with shortness of breath. He is unwell and has a worsening cough. He has a past medical history of COPD and hypertension. He is full code, and he is on droplet contact precautions. His nurse notices that he has increased work of breathing and decreased O2 saturation. He also has hypotension and tachycardia. He places the patient on nasal cannula and ensures the patient has a surgical mask over top. He should consider putting the patient in a more upright position. He may need to provide higher FiO2 oxygen via a high-ox mask with a filter if needed. O2 delivery is dry to avoid nebulized humidity, which may enhance aerosolization. He recognizes the patient is at risk for rapid deterioration and calls for help.
Can I get a protected code blue, please?
He doffs, leaves the room to get help, to brief the code team, and to change into enhanced airborne precautions PPE. Here are 3 pearls. Consider intubation if the patient requires more than 4 to 6 liters of oxygen by nasal prongs or 40 to 50% FiO2 to maintain a saturation of greater than or equal to 90%. Also consider intubation if the patient has signs of respiratory fatigue. You may also want to consider it if there is hemodynamic instability or decreased level of consciousness. Consider using enhanced airborne precautions not just for patients with respiratory complaints, but for all undifferentiated critically ill patients. If possible, an intubation should be planned. Arrange for early transfer to the ICU, and have a dedicated airway team present if possible. When team members arrive, every team member should be assigned a role. It's important to limit staff entry into the room to those essential for the intubation. This is to minimize exposure. There is an inside team, which at a minimum has a leader who's often a doctor. They usually manage the airway, but it's important to use the best intubator available if possible. This might be a respiratory therapist, an ICU physician, or an anesthetist as some examples. The team also includes a respiratory therapist or an intubation assistant, and a nurse to monitor, to start the IV or intraosseous line, and to administer medications. You could consider having an extra physician in the room as a backup. The outside team includes a nurse support person who charts and communicates between the inside team and the outside team, a runner who gets medications and equipment, and a safety officer. This might be a separate individual, or if there are not enough staff, this role could be assigned to another outside team member. The safety officer duties include watching for infection control breaches and supervises donning and doffing. It is nice to have backup staff in full personal protective equipment to be ready to go inside the room if needed. During the team pre-brief, the team members that arrive huddle before they enter the room. Roles are assigned usually by the leader.
As a team, we're just going to make sure we have our roles delineated for a pre-brief before going in. So as the MD, I'll be in charge of the intubation.
The team is reminded that there is enhanced airborne precautions because intubation is a known aerosolizing procedure. If possible, avoid nasal prong oxygen over 4 to 6 liters per minute or nebulized humidity. Avoid BiPAP. Do not use non-rebreather masks unless they have a filter, like a Tavish mask. And don't use nebulizers. The team will confirm the method of two-way communication to be used between the inside and outside teams.
RN, you're going to be charting. You'll also be in charge of the two-way communication from inside to outside the room.
Often two-way monitors or speakerphones are used. It's important not to use a phone that you have to hold up to your ear or face, like a cell phone. The team will plan what medication and equipment needs to be brought into the room. Medication kits are recommended, and they should include ketamine for induction, rocuronium for paralysis, and phenylephrine for hemodynamic support. These are the first-line medications that you would use in a protected intubation. An enhanced airborne airway kit, including things needed for the intubation, should be brought into the room as well to avoid having to bring in the crash cart or take multiple trips inside and outside the room. Have a standard and alternative airway management kit available, including a surgical airway kit. Donning of personal protective equipment includes 5 general steps. Number 1, perform hand hygiene. Number 2, put on a gown. Number 3, put on a mask, or in this case, an N95 respirator. Number 4, put on eye protection. And number 5, put on gloves. And it's important to have a visual aid to assist you. This patient is on droplet and contact precautions. Because he needs to be intubated, team members need to don enhanced airborne precautions PPE. This means they wear an N95 mask instead of a surgical mask, a face shield, and possibly a bouffant cap or head cover. Step 1 is to perform hand hygiene. You want to ensure that you remove all personal items like a stethoscope or jewelry. Step 2 is to put on a gown. You want to ensure that your gown is not too big. You want to tie your gown in the back and not the front, and you want to ensure that your neck is not exposed. You put on your N95 mask, top to top, bottom to bottom. Mold the metal strip of the N95 mask to your face using 2 hands. And it's important to do a seal check. Your eye protection or face shield. And finally, you put on your gloves. Extended cuff gloves are preferable, but not always available. The intubator and the respiratory therapist could consider having double gloves. It's important that your gloves come up over your gown and that there is not any exposed skin between the end of your gloves and the cuff of your gown. Some healthcare workers like wearing a bouffant cap, but it is not required. If you wear one, it should come over the front of your visor or face shield. The team lead has now donned her PPE and can enter the room. The team members, after having donned their personal protective equipment, then enter the room, and they go over a shared plan. They assess the patient's airway, and verify their code status. They go over their intubation plan, which includes how they will oxygenate the patient, how they will perform a rapid sequence intubation with full dose paralysis, and they will have a plan A, B, and C for intubation. Plan A is meant to maximize first attempt success and is to intubate with a video laryngoscopy and consider a bougie. Plan B is to use a laryngeal mask airway, and Plan C is to consider a rescue maneuver like a bougie-assisted cricothyrotomy. They also go over their post-intubation sedation plan and review that the priority is to get the patient intubated and onto a closed, filtered ventilation circuit quickly. If possible, pre-oxygenate the patient for 3 to 5 minutes or until their saturation is above 90%. Things you can do to maximize oxygenation include using a high-ox aerosol filter mask, bag valve mask without bagging. It's important to note that a bag valve mask needs a viral filter. We did not use a viral filter in this shot to conserve equipment, but a picture is located in the bottom right corner. In general, you want to avoid bagging because it can increase aerosolization. But if you need to, use a 2-hand seal, which is when one person holds the mask with 2 hands and the second person bags. For the same reason, you would avoid an oral airway. Next, the team will perform a rapid sequence intubation with full dose paralysis. Ketamine and rocuronium should be your first line. Most people need around 100 milligrams of each, but you should double check your dosing. It's important to wait 45 seconds after administering the medications for good effect, and this is to prevent coughing, which can enhance aerosolization. You also want to have a pre-mixed pressor available. The team is intubating with video laryngoscopy. Use a stylet to increase first pass success. If the patient required compressions, which they do not in this scenario, you would want to pause compressions while intubating. After intubation, inflate the cuff immediately prior to bagging. It's important to have a viral filter between the tube and vent circuit. Once the intubation has been complete, you want to confirm the position of the endotracheal tube. This can be done by visualizing the tube passing through the cords during the intubation, by capnography, or by chest x-ray. There is a recommendation in some places to delay the chest x-ray by 15 to 30 minutes post-intubation, but this is not universal. Often, no immediate auscultation is done to confirm endotracheal tube placement if possible, to minimize contact with the patient. Post-intubation, immediately remove your outside glove layer if you double-gloved. Post-intubation, there are several things the team must consider. The patient needs sedation, and for this, they will use ketamine. Alternatively, they could use propofol with fentanyl or midazolam with fentanyl. You want to optimize ventilator settings and consider pressors, such as push-dose phenylephrine or a norepinephrine infusion. And the team should consider placing an NG tube to avoid further provider exposure in the near future. When the patient is stable, the team should clean the room as per their local infection control procedures. When the patient is stable, the team can doff, exit the room, and they should notify IPAC. Doffing has 6 main steps visualized here. Always try to refer to a posted visual when doffing to ensure you follow the correct steps. This is a very important part of a protected intubation. This is because doffing is a high-risk moment to contaminate yourself, and hand hygiene is a critical part of doffing safely. First, if you have a head cover, remove it. Next, remove your gloves. Then you remove your gown, and you perform hand hygiene. This is often done inside the room. You remove your face shield, perform hand hygiene, and then you remove your mask and perform hand hygiene again. In some institutions, you remove your face shield outside of the room. Doffing procedures may change in some settings, like if there is an anteroom. There also may be institutional variation. Last, but definitely not least, the team should debrief. They should identify key moments in the intubation, talk about lessons learned, and provide support to each other if needed. Here are some key takeaways from this video. In general, you want to avoid aerosol generating actions. You want to keep both the number of people and duration of exposure to a minimum. You want to ensure you are wearing the correct personal protective equipment and that you doff under supervision. Use clear plans and checklists wherever possible. Think ABC, airway, breathing, circulation. Secure the airway first to protect your team. As a disclaimer, this video should give you a general overview of a protected intubation. However, individual protocols at different institutions may have details that differ, and you should be aware of your local policies and procedures. As another caveat, be prepared for personal protection recommendations to change or vary between countries, regions, or even institutions. Supply chain issues may arise and shortages can occur. Own the responsibility for your personal safety and those around you.